make the
Now, can you see my presentation?
but there is something wrong that actually we see. Yeah.
You should see the original classification of Chiari 1, 2, 3, and 4.
Yeah, we're seeing that, but we're seeing you as well as half of it. So if it's possible, maybe if you could just adjust that for us.
How do I do that?
If you exit and then, yeah, here you should have a slideshow somewhere. Sorry, it's in German. Otherwise, I would have told you. Any German friends can help?
Well, I presume
Okay.
I just continue. Otherwise, we use too much time.
If you could increase the size of your thing on the right side. So can you see two pictures there in front of you, yourself and this?
No.
No, it's okay. Then just carry on. I think we'll manage.
Okay. Is this better now?
Yeah, we'll manage. It's okay.
Okay. So we already heard about the classification by Hans Chiari, 1, 2, 3, and 4. I can quickly go through it. Chiari 4 is a hypoplasia of the cerebellum with a communicating fourth ventricle. The Dandy-Walker malformation is related to it, likewise with a cerebellar hypoplasia, but an obstructed dilated fourth ventricle representing the Dandy-Walker cyst. Here you see a Chiari 4 with a normal-sized posterior fossa and no enlargement of the posterior fossa, and here, by comparison, the large Dandy-Walker cyst with the Dandy-Walker malformation, just to define these two signs and types. And then Chiari 2, already heard, is related to myelomeningocele and spinal low pressure syndrome in utero, which causes herniation of cerebellum and brainstem into the spinal canal, enlarging the foramen magnum, associated with a small posterior fossa and hydrocephalus as soon as the child is born, and it's a clear-cut CNS malformation. Chiari 3 has an additional occipital encephalocele on top of it. We've already seen that. Chiari 2 here, a typical example, with the enlarged foramen magnum, the beaking of the mesencephalum, the wide interthalamic adhesion, and here, by comparison, the Chiari 3 with the occipital encephalocele associated together with the Chiari 2. And I like to emphasize on this picture on the left, the large sinus you can see inserting right at the foramen magnum at the posterior rim, which is why you shouldn't decompress the Chiari 2 at this area, because you will run into trouble with this large vein. Chiari 1, by comparison, is a completely different disorder, characterized in the congenital form by a small posterior fossa. It is not a CNS malformation, but the cerebellum simply has to adapt to the altered posterior fossa size. And the second type of Chiari 1 is the acquired one. We've already heard about this, related to craniosynostosis, birth trauma, posterior fossa tumor, hydrocephalus, spinal CSF loss, or vascular malformations. If you want to compare Chiari 1 and Chiari 2, there are some important aspects to notice. First of all, the site of compression in Chiari 1 is in the foramen magnum, where it is in the cervical canal in Chiari 2. Hydrocephalus is only affecting a minority in Chiari 1, but the overwhelming majority in Chiari 2. And a tethered cord is rare in Chiari 1, but almost obligatory in Chiari 2, related to the myelomeningocele. So Chiari 1, commonest craniocervical malformation, and it can be associated with other skull-based malformations, such as a shortened clivus, occipital hypoplasia, or malformations of craniocervical joints. The pathophysiology has already been mentioned. Brainstem compression is one. CSF flow obstruction leading to syringomyelia is another mechanism. Arachnoid scarring is another mechanism. Hydrocephalus, and there's also some patients who will have craniocervical instabilities. So I'd like to show you this slide, which is not too familiar to most neurosurgeons. and that's concerning the different growth periods of the human brain after birth. If you look at the time of birth, then you will find that the cerebellum, in relation to its adult size, is the smallest part of the human brain at this time. And the growth period goes well up to 18 months of age. So by the age of 2 or 3 years, the cerebellum has reached its adult size. By comparison, other parts of the human brain are much smaller, much larger at the time of birth and will not increase so much in volume as the cerebellum. And this may be the cause why symptoms of Chiari 1 and Chiari 2 are so dramatic in the age group under 2 years of age, where it can be a life-threatening complication, as already mentioned by my previous talker. So once the patient has reached the age of 3 and the cerebellum has outgrown, the symptoms of a Chiari malformation are not as dramatic and are more in a chronic, slowly progressive fashion. Interesting to note that in children, occipital headaches affect only about half of the patients, whereas it's very common in adults. And scoliosis is probably one of the leading symptoms in Chiari 1 in the young age group. So what you have to check when you see a patient, look at the amount of tonsillar descent, and remember that depending on the growth of the brain, the growth of the skull, a tonsillar descent of 6 millimeters is normal in a child up to the age of 10, whereas the 5 millimeter applies to patients between 11 and 30. And as older the patient is getting, the descent is retreating because of shrinkage of the human brain with ongoing age physiologically. So syringomyelia in Chiari 1, up to 50% in young children, in adults, and it's more close to 75%. So we have to also look at other skull base anatomy and the anatomy of the craniocervical joints in patients with Chiari 1. We have to look at the COC1, C1-C2 joint. We have to check the clivus canal angle. We have to look for occipitalization of C1, and we have to look for evidence of basilar invagination. Here you can see the normal joint anatomy of COC1 and C1-C2, and the criteria which are used to diagnose instabilities of COC1 are the Harris measurement, as you can see here. Another is the Schmidt-Fischer angle, looking at the angle of the both condylar joints. If that is increasing beyond 130 degrees, it indicates condylar or C1 hypoplasia. But most interesting is a recent paper from China showing the different types of condylar dysplasia that can give rise to COC1 instability. And what you can see here in this patient is a Chiari 1 with a basilar invagination type 2. You see the medullary compression from the odontoid, but if you look at the condylar joints on both sides, you see that they are luxated. So this is a COC1 luxation in a patient with a type 2 basilar invagination. So check for the anatomy of craniocervical joints in patients with Chiari 1. Similar for C1, C2. We know the normal definition of C1, C2 instability with pathological distance between atlas and odontoid increasing 3 millimeters. We consider this unstable. But we also have to look at the C1, C2 facet configurations. And if you see, as in this case here, anterior slippage of C1 over C2, that's a clear indication of instability. The clivus canal angle is also interesting to look at because it will give you an indication whether there is craniocervical kyphosis, and this can be a sign of craniocervical instability. Here you have a patient with occipitalization of C1. You can see it on the coronal and on the parasagittal planes quite clearly with a normal appearing C1, C2 joint below. Basilar invagination is defined by a line between the posterior rim of foramen magnum and the hard palate. If the odontoid peg crosses this Chamberlain's line by more than 5 millimeter, this is considered a basilar invagination, and there are a number of bony malformations associated with it. They all are associated with reduced posterior fossa volume, so Chiari 1 is a very common association with basilar invagination. There are two types according to goal, depending on the presence or absence of a C1, C2 dislocation. And here you can see the two types, one with the atlantoaxial dislocation, where the odontoid is entering the posterior fossa, and type 2, where the odontoid peg is staying below the foramen magnum line, but still crossing Chamberlain's line, as nicely seen here. So the neuroradiology has to check for progressive tonsillar descent. So if you have a chance to look at different MRI scans taken over a certain amount of time, and you see a progressive tonsillar descent in a patient older than 3 years of age, you have to remember that the cerebellum is no longer growing. So if the tonsillar descent is progressing, then you have either spinal CSF loss or an increased ICP from hydrocephalus or a posterior fossa tumor, or you have progressive craniocervical kyphosis or atlantoaxial dislocation. So this has to be looked at if you see a progressive tonsillar descent beyond the age of cerebellar growth. And here's an example of an adult patient with basilar invagination type 2 and increasing cerebellar descent over a period of 6 years related to progressive craniocervical kyphosis. And here, a similar picture with an atlantoaxial dislocation. So differences between Chiari 1 and Chiari 2. I have to add basilar invagination affects about 10 to 20% in Chiari 1 and is rarer in Chiari 2. So in summary, Chiari 1 is a bony malformation, while Chiari 2 to 4 represent CNS malformations. Chiari 1 is related to an undersized posterior fossa. Chiari 2 is related to an intrauterine CSF loss via the myelomeningocele. Both Chiari 1 and 2 may be associated with malformations of the skull base and craniocervical joints. Progressive tonsillar descent beyond age 3 indicates a disease process related to raised ICP, spinal CSF loss, or progressive craniocervical kyphosis. Thank you.
Thanks, Jorg. That was excellent, brilliant talk. If you have any comments, then we can have the discussion at the end otherwise.
Yeah.
Okay, we move on, and hopefully, Jorg, would you like to introduce the next two speakers, please?
The next speaker, according to program, is Juan José Mesadri, who will talk about indications for surgical interventions in Chiari malformations.
All right, thank you. I will share my.
Can you please unshare yourself?
I will try.
Jorg, please.
Unshare.
Okay.
Just 1 second. Jorg is unsharing, and then we move forward.
Oh, sorry.